All right. Thanks again, Dr. Spella. And I apologize yesterday. I have a granuloma on my vocal cord that sometimes acts up and gives me laryngitis while I'm talking. Very challenging sometimes. All right. Well, you guys made it to the last day. Congratulations. And you got to go through me twice before you leave, so I pity you guys. First, we're going to talk about inherited immune deficiency disorders. These are diseases that in many cases are quite rare, but the information that we've gathered from researching them has really helped us with things like HIV in dealing with it more effectively. In many cases, these diseases are so rare that there are more researchers researching the diseases than people who actually suffer from them, but they seem to show up on board exams more than in clinics because many of them have triads, which board examiners love, you know. All right, so sometimes trying to navigate the whole plethora of different immune deficiency disorders can be difficult, so I'd like to help you sort of compartmentalize and conceptualize these diseases to make it easier to sort of deal with them on board exams. Although keep in mind that the immune system is an integrated network of cells and molecules and cytokines and tissues that really taking one portion out of that network kind of affects a lot of things downstream. But again, for compartmentalization and just thinking about these diseases, I've sort of divided them up into these categories. The two large categories are the adaptive immune system and the innate immune system. Now, the adaptive immune system, these are cells and molecules that have specific receptors that bind to specific protein sequences on infecting organisms and help direct the rest of the immune system to attack and kill those organisms. And so the parts of the adaptive immune system are the B lymphocytes, which make immunoglobulin or antibody, and T lymphocytes, which provide cell-mediated immunity. And again, these have specific receptors that sit there waiting all their life for the right antigen to come along. And when they do, then they start proliferating and start getting activated so that they can help the body fight the infection. And then the innate parts of the immune system, and we'll just use phagocytes and complement proteins as examples. These are non-specific reactors, and they typically require the adaptive immune system to direct them to do things, because if they start getting active, they kill everything, and they kill your self tissues as well, so you can get a lot of bystander inflammation and damage. So we'll think about those four compartments, and we'll talk about diseases that are examples of each of these four compartments. Now, the largest group is the B lymphocyte, or the antibody component of the immune system. Over half of the immune deficiency disorders are in this category. Now, antibodies provide a lot of important functions in our immune system. One is neutralization. So neutralization implies that the antibody will bind to, say, a bacteria and coat it so that it becomes so cumbersomely loaded with bacteria that it's hard for it to get places. So if you guys went out and got, some fruit out there and maybe there's an E. coli floating around on the fruit there, your IgA in your gut will just coat that piece of that E. coli and prevent it from gaining access to your system. Opsonization refers to a process by which there are receptors on, say, phagocytic cells for immunoglobulin. And so the immunoglobulin will bind to the bacteria, and if there are things that cause phagocytes to come into the area, the phagocyte will bind to this antibody-antigen complex and will be more likely to engulf that antigen or bacteria and kill it so it doesn't cause you infection. Sort of like coating the bacteria with like chocolate syrup or something and making it more likely to be ingested. Also, immune globulins activate the complement system, and the complement system then can actually cause bacterial lysis through its cascade of activation. And typically, antibody-antigen complexes, immune complexes, are the site where complement gets activated. And complement is most avidly activated by immunoglobulin M, followed by IgG3, 1, 2, and then IgA, IgE, and IgG4, as well as IgD, do not have complement activity. And then there's a process called antibody-directed killing, where antibodies that are already on phagocytes can actually direct the phagocytosis. So a lot of important infections that help us kill mainly bacteria. Now, there are 5 classes of immunoglobulin, and these are IgG, IgM, IgA, IgE, and IgD. Why it's not A, B, C, D, E, I don't know. But what we know is that IgG, or gamma globulin, is the major immunoglobulin in your bloodstream and crosses the placenta. So when babies are born, they have normal adult concentrations of IgG. Important board question. It has a half-life of about 23 to 28 days. So usually after about 4 months, you get the nadir of neonatal IgG, and that's usually when kids have their first ear infection. It's around age 4 to 6 months when they're at the lowest IgG concentration in their bloodstream. There are 4 subclasses of IgG that have mildly different functions. Now, IgM is the primary antibody responder. It's less efficient than IgG because it doesn't have memory antibody function. And so basically IgM is there when you first encounter a particular organism, and then the immune system then creates a memory antibody response so that subsequent encounters with that organism are much more efficiently dealt with. But IgM is very effective at activating complement. Complement activation causes a lot of acute phase reaction stuff. So a lot of times, again, your first infection with an agent also gives you more fever and more constitutional symptoms because of all the complement activation. IgA is the major secretory antibody, produced in the largest quantity of any immunoglobulin in your body, but because most of it's in your GI tract and your respiratory tract and secretions, the half-life's only about 3 days. So in actual serum concentration, it's probably second or third with IgM. There are two subclasses of IgA as well. Now, IgE is the immediate hypersensitivity antibody. It provides assistance with fighting helminthic parasite infestations as well, but in most people living in westernized societies, it mainly just causes allergy problems, and it's, again, lowest concentration. And IgD is a transitional form. The only significance of IgD is that there is a periodic fever syndrome called hyper-IgD syndrome, where that will be measured if you have periodic fever. Now, if you don't have immunoglobulin, what happens? Well, immunoglobulin deficiencies, again, are the most common. IgA deficiency in particular, the most common. And these patients tend to have recurrent sinopulmonary infections with high-grade encapsulated bacteria. As you might imagine, since immunoglobulin is made by B lymphocytes and then secreted into your bloodstream, extracellular pathogens would be the most important for antibody deficiencies. And in fact, they have very few problems with viral infections or fungal infections, with some rare exceptions. Mainly enteroviruses seem to have unique susceptibilities with these patients. But they do have relatively good outcomes if we recognize them early, and if they are lacking IgG antibody function, then we can actually replace it with immunoglobulin replacements such as IVIG. So let's talk about some individual diseases now. First, we'll talk about X-linked agammaglobulinemia, otherwise known as Bruton's agammaglobulinemia, for Colonel Ogden Bruton, who discovered the disease. This is a disease where these boys have no immunoglobulin whatsoever, or just rudimentary amounts of it. And they start getting recurrent bacterial infections at around age 4 to 6 months, when the maternal IgG wanes away after those 4 half-lives or so. And what they noticed when they first described this disease is these babies have a very small amount of lymphoid tissue. I mean, you got these kids with all these pus coming out of their ears and pus coming out of their nose, and yet they don't have big lymph nodes and they don't have big tonsils. And why is that? Well, because they don't have any B cells. And B cells make up the cortical follicles of your lymphoid tissue, and so without those, even though these kids have infections all over the place, they don't get reactive adenopathy very often. Now, these patients have that unique susceptibility to enteroviral infections, and the reason why these viruses are so important to them is really not that well known. But say Coxsackie virus or echovirus can cause life-threatening meningoencephalitis in these children. And back in the days when we used to give oral polio vaccine, these kids would actually get polio from the vaccine or from siblings that had it and then brought it home. Now, if we see these patients, we start them immediately on immunoglobulin replacement therapy with IV or sub-Q IG, and it replaces IgG so they don't get the septicemia and the deep tissue infections that these kids are normally prone to get. They can still get recurrent low-grade infections like sinus infections and ear infections at a lower frequency because we can't replace IgA that they're missing. This is due to a defect in the X chromosome of a gene called BTK that's important for B cell development in the bone marrow. It has nothing to do with immunoglobulin genes whatsoever. Now, common variable immunodeficiency is much more common and much more variable. And in fact, it's probably multiple diseases with several genetic markers have been found. That probably is just thrown into one sort of pot of sort of more of a phenotypic description rather than a true single disease. This also causes recurrent bacterial infections, but patients who are labeled with common variable immunodeficiency typically don't start at birth with their infections like the X-linked agammaglobulinemics. You may not even see this present until adolescence or young adulthood. And it seems odd that a genetic disease would present in young adulthood, but there are several genes that have been identified that actually have this pattern. It's probably autosomal recessive inheritance in most of the diseases that have been described and those where we still don't have a gene isolated. But what's very interesting is that many of these patients have what might be termed more an immune dysregulation, where they lose antibody responses to, say, infecting organisms, non-self, but then they gain antibody responses to self-antigens, and they start getting autoimmune diseases, like autoimmune hemolytic anemias or thrombocytopenias, or even JIA-like diseases. Now, the problem with this is these people are treated exactly the same as the X-linked agammaglobulinemics with IVIG or sub-Q IG immunoglobulin replacement. But there are trace amounts of IgA in the preparations that are available, and they may be making autoantibodies against IgA, so they can get transfusion reactions sometimes when we treat them. So if we have somebody with absent IgA in this circumstance, we're very careful with their first treatment of IVIG or sub-Q IG. Selective IgA deficiency, the most common antibody deficiency or immune deficiency in general, about 1 in 1,000 of the general population. Most of these patients are asymptomatic and get picked up on a celiac disease workup by our gastroenterologists or primary care pediatricians. They get IgA, it's part of the panel, and it comes back 0, and they come in and we see them, and they really have no infection history, and we basically send them home and just remind them to tell people when they get a blood transfusion to be careful because they may have anti-IgA autoantibodies as well. And we also see many patients where numerically the number is low but not absent, and those patients rarely do they have any symptomatology whatsoever. But there are a cadre of patients, especially those with absent IgA antibodies, where the concentration is less than 10 milligrams per deciliter, and they may get not septicemia, but things like recurrent ear infections, recurrent sinus infections, and even pneumonias. Now, in early studies, about 15% of these had an IgG subclass deficiency as well, but that hasn't been corroborated with recent data. So you may see a coexisting IgG deficiency. Certainly, if you see a patient with selective IgA deficiency and recurrent infections, we do recommend they be evaluated more extensively. That segues us into IgG subclass deficiency, and there are 4 subclasses of IgG, and thankfully they are 1, 2, 3, and 4. And the odd-numbered ones have been traditionally described as responding better to protein antigens like tetanus toxoid or diphtheria toxoid, and the even-numbered ones seem to respond best to polysaccharide-based antigens like pneumococcal polysaccharides, but there's a ton of overlap. So just having an isolated low number of one of these things is not necessarily a reason to start somebody on IVIG or immunoglobulin replacement. So when we see this, we immediately try and measure antibody titers to immunogens like, diphtheria, tetanus, and pneumococcus. And if they have low antibody titers, we re-immunize them and see if they give a booster response. And if they don't, then they probably do have a defect in antibody responsiveness. And those people usually are treated with immunoglobulin replacement. Whereas, again, isolated low concentrations are really not necessarily associated with poor antibody function. And so gamma globulin replacement in this situation is not really indicated. Now, the last disease we'll talk about in this group of immune deficiency disorders is hyper-IgM syndrome. And as the name applies, there is an elevated IgM with other isotypes being very low. Sorry. Okay, there. And the disease level tends to correlate, so if they're infected frequently, their IgM goes up with the frequency of infections. And what happens is that when your immune system creates a memory antibody, there is an interaction between the helper T lymphocyte and the B lymphocyte that's making the antibody. And so when you have that interaction, which is between this molecule called CD154 or CD40 ligand with CD40 on the B cell, it provides a signal that tells that B lymphocyte to switch from IgM production to something like IgG production. And then those IgG clones of lymphocytes are there ready to fight the next infection much more efficiently than starting off all over again with IgM. But with hyper-IgM syndrome, every infection is like your first one, so you get lots of infections with a lot of acute phase reaction, a lot of complement activation, and so they get really sick each time. And they really have no memory antibody. So, because this is a defect actually on the helper T cell and not on the B cell, you can get some opportunistic infections as well. That are indicative of a mild T cell defect as well, or cell-mediated immune defect. So ascending cholangitis with cryptosporidium is the classic infection you see in these people, in addition to the bacterial infections that you get with antibody deficiency. So these people are treated with IV or sub-Q gamma globulin replacement therapy, but we have to monitor their liver functions because if they get ascending cholangitis, it's very hard to treat, very hard to get rid of, and they end up losing their livers. So a lot of these patients end up going for a bone marrow transplant as well. Thankfully, again, a fairly rare condition. Next, we'll talk about T lymphocytes, which provide cell-mediated immune function. And basically, T cells are the central players in your immune system, and it's no wonder that a virus that attacks CD4 helper T lymphocytes basically wipes out the whole immune system with HIV. Now, what do T lymphocytes do? Well, they provide help for immunoglobulin production with cytokines and with that interaction between the helper T cells and the B lymphocytes. They also kill virally or fungally or intracellularly infected cells. They can recognize altered self and kill it so that it doesn't spread to the rest of the cells. It also provides a function to reject incompatible tissue because it recognizes different tissue types and provides a bit of a challenge for transplantation biologists. It also recognizes altered self and provides surveillance against malignant transformation. And it provides a variety of cytokines that direct phagocytes and other aspects of the immune system. Extremely important cells. And so if you have a defect in cell-mediated immunity, the severity depends on the amount of the percentage of T lymphocytes in your whole system that are lost, or maybe the loss or amount of loss of the thymus gland that provides educational functions to help immature T lymphocytes become mature functioning members of immune society. So what happens when you have cellular immune deficiency is you get recurrent infections with intracellular pathogens like viruses, fungi, and protozoa, and these are often what we would consider opportunistic infections. Bacteria, or not bacteria, but fungi, viruses that we live with protozoa that we live with all the time, and those of us with normal immunity, we seem to live, without any harm from these organisms, but folks with the immune defects can't tolerate even those that are just commonly in our systems. And these are failure to thrive kids. They tend not to grow. They get diarrhea and wasting. And again, if they have a complete loss of T lymphocytes, then this happens from birth. There are also risks with live virus vaccines, and the vaccine strain can cause fatal, say, measles in somebody who has SCID or something like that. And they also have a risk of graft versus host disease because they can't reject incompatible tissue. Say if they get a blood transfusion that's not irradiated, and the T lymphocytes from the donor will then basically reject the recipient, causing graft versus host disease, which again can be fatal if the patient has absolutely no cellular immunity. And also there's risk for malignancy because of the loss of the surveillance function. So these children, depending on how much defect they have, are at severe risk for early death. And for that reason, Ohio and many other states now provide newborn screening for SCID so that those kids can get bone marrow transplanted early, because the earlier they get transplanted, the better the outcomes. But first we'll talk about DiGeorge syndrome, because this is probably the example of a pure, if you can have a pure T-cell defect. So it was named for Angelo DiGeorge, an endocrinologist in St. Christopher's Hospital in Philadelphia, who described these children who had the triad of neonatal hypocalcemia causing tetany, which was why he was called in. They all seem to have congenital heart disease, usually something involving the aortic arch. And then they also had immune deficiency, and typically they started with severe candidiasis that they couldn't get rid of. And he postulated that because the parathyroid glands and the thymus gland were both housed in the third and fourth branchial pouches in embryologic development, that maybe there's a defect there. And certainly we normally keep the fourth aortic arch to the left, and so that seemed to correlate. And so, in fact, that's been proven to be the case, and is often a defect on chromosome 22q11 being the most common gene defect associated with that constellation of defects. Now, these patients have a lack of thymus tissue, and it may be complete lack or it may be partial lack, and depending on the degree of thymic tissue that's still present determines the severity of the immune deficiency. Certainly we've seen cases where there's absolutely no thymus function, there's absolutely no T lymphocytes, and these people are severely deficient. And then there are other cases where there's enough thymic tissue to give us low but not absent function that prevents them from having any of the severe infections. Now, these patients get early infections and mucocutaneous candidiasis, failure to thrive, and severe risk for life-threatening graft versus host disease if they get a blood transfusion for their heart surgery. So cardiac babies, in our institution, every one of them gets irradiated blood before they get transfused. Now, these children also have some mildly dysmorphic faces, like low-set malrotated ears, or hyper or hypotelorism, or even micronathia, like a Pierre Robin type picture. And again, the severe form requires immune reconstitution. Currently, that's either bone marrow transplantation or fetal thymus transplant. Now, severe combined immune deficiency, or SCID, like common variable immune deficiency, is more than one gene defect, but it's more of a phenotypic description of children who have no B cell function and no T cell function. So, these are the most severely immune deficient patients that we see, and they have early problems with opportunistic infections in Candida, and then they start getting septicemia and bacterial infections at around 4 months of age when mom's IgG kind of wanes away. And they have no immunoglobulin, no cell-mediated immunity, and there are several genetic forms that have been described. The most common is the X-linked form, about 50%. that is due to a defect in the common gamma chain of the IL-2 receptor that's shared with IL-4, IL-7, IL-9. And it's probably IL-7 that's the most important for that. There are several autosomal recessive forms, one that involves JAK3, which is a signal transduction protein for that IL-2 receptor. And then others like adenosine deaminase deficiency. There's a defect in the purine salvage pathway that converts adenosine to inosine. And so adenosine metabolites build up into cells, and they're particularly toxic for T lymphocytes and kill them. And then RAG1, RAG2, these are recombinase activating genes. And when those genes aren't available to cause gene recombinations and rearrangements, you never develop any functional T cells. And there's an Artemis deficiency in the Athabascan tribes of the Navajo in the southwestern United States that provides a unique, it's almost like a radiation-sensitive skid where they get too much sunlight or any radiation, and it causes problems where they can't really repair those defects, and they lose T cell function that way. So these patients require absolutely, as early as possible, immune reconstitution with bone marrow transplantation. Other combined immune deficiencies that are less complete but cause some interesting constellations of symptoms, most of them with triads. Again, board examiners like triads. Wiskott-Aldrich syndrome is an X-linked disease that causes the triad of eczema that looks just like allergic eczema, thrombocytopenia that often requires splenectomy, and recurrent infections. Again, this isn't as severe a defect as, say, X-linked agammaglobulinemia on the antibody side or, say, SCID on the T cell side, but enough that they really can have problems with malignant transformations when they're in their second decade of life or severe varicella infections. These people typically get bone marrow transplants at some point in their life. Ataxia telangiectasia gives you a triad of cerebellar ataxia that's typically the first thing that develops and becomes very prominent by around age 5 or 6 with a very shaky sort of walking gait. They also get telangiectasias or dilated tortuous blood vessels in their eye sclera or on the pin of their ears, and then they get a progressive loss of immune function because it's really a chromosomal repair defect. And so usually second or third decade of life, they die from infection or malignancy. Now, hyper-IgE syndrome is an interesting disease that gives recurrent abscesses, also cavitary things in the lung, but they also get sky-high IgE levels of uncertain etiology. And they also get some dental abnormalities with conical, round, misshapen teeth. All right, next we'll talk about the phagocyte arm of immunity. And again, this is the innate immune system, so phagocytes get directed by those adaptive cells to provide their terminator functions, which is basically to engulf and eat bacteria and stuff. And this would apply to both the polymorphonuclear leukocytes or neutrophils, macrophages, and tissue-specific macrophages like Kupffer cells in the liver or microglia in the brain. And phagocytes do lots of stuff, amongst which they provide, there's a chemotactic function. So there are chemoattractants that are made during inflammatory responses that will then attract the phagocytes to go into the tissue where the infection is and arrive there to do their thing. And so it's an actual functional chemotaxis that develops. Then they adhere, say, to the surface of the bacteria, and then they enzymatically digest it and oxidatively degrade it. And there are several other functions that phagocytes engage in, but these are things that you can actually measure in a laboratory. Now, when phagocytes can't do their thing properly, say they can't get out to tissues or if they can't kill things properly, we tend to get abnormal neutrophil counts because, okay, if your neutrophils aren't marginating or they're not going out into tissues, then they're staying in the bloodstream and you get a sky-high elevated neutrophil count if you can't chemotax out to tissues. And also, the immune system is kind of interesting in a way. If it feels like it's not taking care of an infection, it seems to cause the bone marrow to churn out more of those puppies, thinking maybe we could just overcome the defect by having more cells. And certainly there are neutrophil defects where they just don't make any neutrophils, where there's a complete neutropenia. So typically when you have a phagocyte deficiency, either it's sky high or it's really low. Usually you don't see normal neutrophil counts. Now, adenopathy is often present. And so, yeah, because the lymph nodes are sort of the forts in the battle against infection. And so, yeah, they'll swell up with the recruits that come in. And so, yeah, you have the battles going on there. And so lymph nodes tend to swell up. Liver, spleen also. Now, people with phagocyte deficiencies tend to get recurrent infections, typically at portals of entry to the body or places where the immune system wants to fight infections. So, skin, breathing in things in your lungs, lymphoid tissues like lymph nodes, liver and spleen, deep tissues like lungs and like liver and things like that, and then oral and anal areas. So these people often get ulcers in their anal area, their oral areas when they have phagocyte deficiencies. Now, Staph aureus is the most common infecting agent in most people with phagocyte deficiencies because most of the infections are in the skin. But you can see some very unusual organisms with certain of these defects that require some mention here. So the first disease we'll talk about is chronic granulomatous disease. Those of you who attended the luncheon yesterday got a very detailed discussion of this condition, so we'll go over it in a little bit less detail. People with CGD are unable to create an oxidative respiratory burst due to a defect in the system of cytochrome P450 NADPH oxidase. And there are X-linked forms, and there are autosomal recessive forms that have been described. Now, the organisms that cause infections are organisms that produce the enzyme catalase, and Staph aureus being one of those. But certainly fungi like Aspergillus do this, and certainly unusual organisms like Nocardia or Serratia, even Chromobacterium violation have been known to cause infections in this condition. In fact, Chromobacterium infections only been described in CGD. And the reason is pretty simple, okay? You have a phagocyte engulfs a bacteria, it's sitting there in the vacuole, and, okay, if it's going through its metabolic processes, it's creating its own peroxides and waste products that eventually will kill it if it doesn't have the catalase to break down the peroxides. And so it can live happy as a clam there if the phagocyte can't kill it with this defective oxidative burst problem. All right, so recurrent skin deep tissue infections, mainly pneumonias and skin infections predominantly, but you can also get abscesses in other places like suppurative adenopathy or liver abscesses. The tests involved right now, the gold standard test is the dihydrorhodamine reductase flow cytometry assay. Several labs still use the old nitroblue tetrazolium test. Both are good tests for picking this up. The DHR test is a little bit better for carrier state detection because carriers of CGD have discoid lupus and maybe milder infections as well. And this responds really well to recombinant interferon gamma. That's sort of the treatment of choice now. We also give prophylactic antibiotics, typically something for staph like trimethoprim sulfa, and then something for Aspergillus like itraconazole. Other phagocyte deficiencies that deserve mention on board exams, one is called Chiari-Kagashi syndrome, which gives the constellation of recurrent staph infections, and where you will see Chiari-Kagashi more often than not is that on a plate of a neutrophil you will see obscenely large granules in the actual electron microscopy of the neutrophil or on a stain. If they're giving you a stain of a neutrophil with these granules in there that just look otherworldly, it's Chiari-Kagashi syndrome. They often can die from hemophagocytosis during an acute accelerated phase that occurs in about 65% of people with this disease. Now, leukocyte adhesion deficiency is a very interesting disease because the phagocytes don't have adhesion molecules, so they can't bind to, say, even the endothelial cells in the blood vessels, so they can't marginate out, and they can't diapedese out because you need adhesion molecules to do those functions. And so you get infections with staph, but with no pus because there's no white cells in the tissue. Now, what you'll see with leukocyte adhesion deficiency, and it's really common to see on board exams, is that these patients have a delayed umbilical stump separation. I mean, it's beyond a month. And this is due to a defect in an integrin leukocyte adhesion molecule that binds to ICAM1 on the endothelial cells. So, delayed separation of the umbilical cord and infections with ulcerations but not pus formation, think leukocyte adhesion deficiency. Cyclic neutropenia, a more common condition where you get cycles of neutropenia every 3 to 4 weeks with infections at the naders, and this typically responds well to things like GCSF. And often it is a temporary thing that will improve with age. Last, we'll talk about the complement cascade of proteins, and again, complement is a cascade of serum proteins similar to the clotting cascade. And so you go from C1 to C2, and you keep going down the cascade, but at each stage, one molecule of C1 is activating multiple molecules of C2, multiple molecules of C3, and you get this amplification that's quite impressive with complement activation. So there are also regulatory proteins involved in this that actually shut off the activation, or you can consume all your complement. Now, C3b is a potent opsonin. So what happens when complement gets activated by an immune complex, and presumably the immune complex involves a bacterial protein, is that when complement gets activated and C1 activates C4, it's a binding protein that binds onto the bacteria, and then when the enzyme C2 breaks up C3, it creates this C3b that also is a binding protein on the bacteria, and that one's a very potent opsonin for phagocytes. C5, its byproduct, C5a, is a very potent chemotactic agent for polymorphonuclear leukocytes, and if C1 through C9 is allowed to go, you actually get a pore formation causing an osmotic killing of the bacteria through cytolysis. So when complement gets activated, if the bacteria is susceptible, you will see multiple pores and holes in the bacteria killing it. But complement also provides an immune complex processing function because red cells have complement receptors as well. And so when immune complexes get formed, they'll actually bind to the red cells, and the red cells will go to the spleen, and then phagocytes there will take off those immune complexes and digest them before those immune complexes start to accumulate and then sort of build up in your joints, your kidneys, and your skin. So again, a lot of complement deficiencies will give you autoimmune type diseases too because of the immune complex buildup. So here's the complement cascade going from C1 to C9. C1 is a protein that has 6 globular heads, C1q, and this binds to at least 2 immune complexes that will cause a conformational change in the enzymes C1r and C1s, causing this activated C1. Anytime you see a line over a complement protein, that means that it's activated. I didn't design this system, by the way. Now, this enzyme breaks up C4, a binding protein, and C2, an enzyme, to cause a complex that's now bound to the bacteria called C42. Right? We used to call it C4b2a. And then that catalyzes the central reaction in complement, causing C3 to be cleaved to C3b, which again is that opsonic binding protein. And then this provides an anchor point for C5 to bind, and this enzyme breaks up C5 to C5a, that chemotactic protein, and C5b, another binding protein. Now, C5b provides an anchor point for then C6, C7, C8, and C9 to gradually wedge itself down further and further and further into the cell membrane of the bacteria until it actually traverses the actual cell membrane. And C9 provides a huge pore that will then cause osmotic loss of integrity of the cell. Now, defects in C1, C4, and C2, because they're creating this C3b, and the receptor for C3b is on those red cells, you mainly get immune complex disease and recurrent infections when you have defects in C1, 2, or 4. And if you, in this terminal attack complex of C5 through C9, defects there cause unique susceptibility to Neisseria infections, and this is where you'll see it on board exams. Kids with recurrent meningococcal meningitis, or teenagers with gonococcal polyarthritis, they have defects in C5 through C9. It'll be on every board exam you ever take. Now, there's an alternative pathway of complement activation where there are proteins, factors D, which is an enzyme, factor B, which is a binding protein, and factor P, which is a stabilizer, that can also cause this reaction to occur. And interestingly enough, defects in these proteins, C3, factor P, factor B, or factor D, result in recurrent bacterial infections like antibody deficiencies have, recurrent ear infections, sinus infections. But more commonly, you will get septicemia because these are clearly serum proteins, and clearly a defect in a serum protein will be much more likely to give you a bloodstream infection. So if you see a bloodstream infection, think also, this complement cascade. So complement deficiencies, they're the rarest of the 4 types of immune deficiency, C2 probably being the most common. And again, classical pathway defects give you lupus-like autoimmune type diseases. And interestingly, they don't show up with positive ANAs, by the way, which makes them uniquely challenging to diagnose. Alternative pathway defects, that factors C3, B, D, P, and some regulatory proteins, factors H and I, that turn off complement activation, give you recurrent sinopulmonary infections. The real one you'll see most commonly on board exams is this C5 through C9 defect, giving you the membrane attack complex defect and recurrent Neisseria infections. Now, there are some other aspects of complement that deserve some mention. As we talked about yesterday, hereditary angioedema is actually due to a defect in C1 inhibitor, often autosomal dominant, and you get recurrent episodes of swelling and areas of trauma, and it's painful, not itchy. And there is an alternative, yet another alternative pathway of complement activation called the mannose-binding lectin pathway, which is sort of a side pathway of complement activation, and the deficiency results in milder bacterial infections that often just get better with age without any treatment. So, just to sum up things, what do we do if we're suspecting immune deficiency? Well, certainly the history and physical exam are very important, the history in particular. And since many of these are inherited defects with X-linked pedigrees, family history is very important. Laboratory tests are essential for pinpointing the diagnosis, and then HIV screening very important because HIV is more common than any of these diseases. And there are 10 warning signs of primary immune deficiency that have been described, 8 or more new ear infections within a year, 2 or more serious sinus infection within a year, real sinus infections, 2 or more months on antibiotics with little effect, 2 or more pneumonias within 1 year, failure of an infant to grow or gain weight, recurrent deep tissue, skin, or organ abscesses, persistent thrush in the mouth or elsewhere after age 1 year, a need for IV antibiotics to clear infections, 2 or more deep-seated infections like pneumonias or internal abscesses, and a family history of primary immune deficiency. Those are the sort of the 10 warning signs that I would keep in mind. Now, for the lab tests for immunoglobulin deficiency, you can measure the immunoglobulins, you can measure antibody titers to immunogens or ABO blood groups, and then you can measure antibody titers post-immunization. And I would commit somebody to IVIG only if their post-immunization antibody titer was low. For cell-mediated immunity, we can do delayed hypersensitivity skin testing, but under age 2, it's not quite accurate. So we tend to rely more on lymphocyte counts, T-cell enumerations and subsets, and proliferative responses to mitogens or antigens in the lab. And again, now we have newborn screening for these T-cell receptor excision circles that can identify SCID very early. For phagocytes, as we mentioned before, neutrophil counts, neutrophil chemotaxis, adhesion assays, and then measures for CGD like NBT, superoxide, or that dihydrorhodamine reductase assay. And then for complement, the CH50 measures the complement activity from C1 through C9. There are assays for virtually every complement component, and there are alternative pathway CH50s as well. And again, for hereditary angioedema, remember we measure C4 as the screening test and then look for C1 inhibitor numbers and function. And then for treatment, remember for antibody deficiencies, IVIG and sub-Q IG can be provided. Aggressive antibiotic therapy after determining the responsible organism, especially for those phagocyte deficiencies, because it might be serratia, it might not be staph. So you really have to go for a tissue diagnosis in that circumstance. Avoid live virus vaccines for T-cell and severe combined immune defects, and irradiate blood products for cardiac babies and anybody with severe T-cell defects. And again, you may need to go for tissue diagnosis with some of these immune defects if you have an infection. For T-cell and combined deficiencies, we tend to give immune reconstitution, which involves bone marrow transplantation, interferon gamma for CGD, screening for associated conditions and autoimmune disease, associated conditions like for DiGeorge syndrome, screening for the hypocalcemia. Always remember to screen for HIV if we have cellular defects, and provide antibiotic prophylaxis for pneumocystis in the cellular immune defects, and for CGD with the Bactrim and itraconazole. And again, carefully monitor for malignancies because these patients are at higher risk. I apologize for again going over time, but I thank you for your attention. I will see you in a few minutes.